And today I'd like to welcome Sue Stoklosa. She has been with us for a few years with University Express, and we love having her. She's very knowledgeable and a great presenter. Sue is a nurse practitioner with 13 years experience in a pulmonary and critical care practice. In this practice, she managed and educated obstructive sleep apnea, or OSA, patients. Sue recently lectured on OSA at the New York State Nurse Practitioner Conference. She currently teaches the next generation of nurse practitioners at Damon College. Sue is also a certified basic life support and advanced life support instructor. So welcome, Sue, and take
Thank
it
you.
away.
Thank you for having me. A pleasure to be here. During this holiday season, it's a great time to start talking about lipids and our fat intake. Sorry. But we'll get, I don't even know what to say about that. So I'm going to start the PowerPoint. Okay, so what do those numbers mean? So you go to your doctor, you have these lipid profiles done. He gives you the numbers, or she gives you the numbers, and what does that mean? What's going on in my body, and what can I do to make them better? So what is cholesterol? Well, it's a type of a lipid or a fat. It's found in all cells in the body. The body needs these fat to work, especially our brain cells. They form the cell membranes. Generally, your body will make all the cholesterol you need.
Hey, Sue, I
Yes.
just want to interrupt for a second.
Am I getting reverb?
No, I don't see the PowerPoint, but
Oh, okay. Hang on.
the others might.
No, probably not. Let me, okay. Thank you for doing that.
Oh, yeah, no problem.
Ah, there we are.
If you want to share.
Yeah. Okay.
Okay, I see it now.
And can you hear me too?
Sure, and if you go into share again and go to start or slideshow, go into slideshow there in your PowerPoint.
Oh, yeah. Okay. I got
And
it.
then hit start from beginning.
Okay.
Okay, perfect. Perfecto.
We'll just go down a little bit.
Thank you.
Okay. Okay, so here we are. So, again, we have the fats in all of our cells. We need them to make the membranes around the cells to hold all the stuff in the cells. Generally, again, your body will make all that you need. We get other stuff in, or we have medicines and things that make us have more cholesterol. The blood cholesterol, the cholesterol that's circulating in your blood, is made in the liver. It's important to make hormones, and it aids in digesting fatty acids. So then it's not fats are bad. They serve a very important purpose, and we shouldn't not have any fats in our diet, but we need to moderate them. Dietary cholesterol is from our animal foods primarily. So you have the fats and you have the cholesterols within your cells. You have cholesterol circulating in your blood that's doing things, again, like making your different hormones and digesting fatty acids. And then we have a dietary cholesterol, which is primarily from animal foods. So what's in a lipid profile? So the your healthcare provider sends off the lipid profile. There's basically 4 things. Sometimes there's a little more, but basically they're looking at 4 things. And we'll talk about these more in depth. High density lipid protein, or HDL. I remember that one, you use the H, it's happy cholesterol. That's the one you want higher. Low density lipoprotein, the low density, the LDLs, you don't want higher. Triglycerides, which are fats, they are more connected with our carbohydrate intake than with fat intake. And then they'll give you a number of their total cholesterol. So the HDL, again, high density lipid profile, protein. LDL, your low density lipoprotein, that's the one that gets us in trouble. The VLDL, some labs will give you this number also. This is the very low density lipoprotein. That really can get you into trouble, but not all of them will give you this number. It's part of the LDL. It doesn't really help that much in figuring out how to treat it. The total cholesterol number you get is the HDL plus the LDL. We talked about the triglycerides is more carbs. The more carbs you eat, the higher the triglycerides are. It's very important with people with diabetes and watching their triglycerides. Screening is recommended to start at 20 years old and then repeat every 5 years if normal. So I would say generally, the general practice that I see is they're not really, most of the primary healthcare providers start maybe at 30, but the screening is recommended to start at 20 and then every 5 years if normal. So again, the components of a lipid profile. So the HDL, or the high density lipid protein, the happy cholesterol. It removes cholesterol from the body. So the nice thing about this is the higher it is, the better it is at removing the cholesterol we don't need. It has a protective effect, especially a protective effect on heart disease. The optimal is greater than 40. And every 10 milligram increase in the HDL will result in a 50% decrease in coronary artery disease risk. Coronary artery disease, which we'll talk a little bit more about, is the disease that gives us heart attacks. So bringing that up even by 10 milligrams has a huge effect on your risk of heart disease. And this picture just kind of shows us, you have the cholesterol being made in the liver, you have it into the bloodstream. Some of it is glumping up here because we have extra, but the HDL comes in and is starting to remove it back to be resynthesized in the liver. Now the LDL, and that's probably if you have issues with your lipid profile, what your doctor is talking to you about. That's the bad cholesterol. This increases the risk of heart disease, and atherosclerosis is the technical name for the plaques and the buildup in the arteries. So, and basically this process in the arteries starts with inflammation. So you have some type of inflammation within the artery walls due to, let's say, smoking. And then those inflammatory cells combine with the cholesterol to form these plaques. So in this picture here, you have the artery, okay? And the endothelium is the lining around the artery, and that's what gets inflamed. And then this area here is the smooth muscle. There's muscle around the arteries. And these arteries, can be anywhere in the body, but we're talking primarily the coronaries, which are the arteries, if anyone was here last week, that supply the blood to the heart. So you start getting this glumpy plaque, soft plaque here, filled with, cholesterol, fatty, for the technical term, clumps, and different cells. And as you see, as it gets bigger and bigger, the blood flow gets smaller and smaller. So whatever this artery is supplying to your body, let's say your heart, your brain, your kidneys, it decreases the blood flow. And some of these cells have trouble getting through. And eventually, or not eventually, but sometimes the whole thing gets blocked. And then you got a problem. So you see, this is the cross section. You got lipids, calcium, cell debris, all making a plaque here. And the blood and the cells trying to get through a very narrowed artery. So what are the goals for the LDL? it used to be, not that long ago, that everybody was the same. We wanted everybody below an LDL of 120, and if you had heart disease, below 100. Well, they realized that not everybody has the same risk factors, and some people with maybe no heart disease but an LDL of 100 should actually be treated. So now it's based on risk factors, and hopefully we can show you the risk, the risk calculator. But the risk factors are things like age, whether you have high blood pressure, whether you have diabetes, what is your cholesterol numbers, and then they give you a calculation of your 10-year risk of having heart problems, and based on that, they decide what your LDL should be. So optimal. You don't have any risk factors. You're a fairly young person. Let me go, based on risk factors, optimal is under 100. Near optimal, 100 to 129. Borderline high, 130 to 159. High, 160 to 189, and very high, greater than 190. And again, how it's treated, how aggressively it's treated is based on risk factors. So your your neighbor may have, you're talking, and they may have the same LDL, and he says, well, my LDL is 120 and I'm not on any medication. And you say, well, mine is 120 and I'm on medication. What's up with that? Well, we look at, again, the risk factors that each person has. So it's really a more individualized treatment than it's been in the past. Just get a little here. I'm a little stuck. Come on.
Did it just freeze? It won't move.
Yeah, it won't move. Yeah.
Well, we'll give it a second.
We'll give it a second to, want to be. Just come on.
Yeah, that's odd. That usually doesn't happen.
I haven't had this problem before. Let's try this. Okay. All right. So,
wonderful.
All right. So these are kind of the things they look at for risks with the lower LDL goals. So somebody who maybe your doctor has said, I want your LDL under 100 instead of under 120 or lower than that. So these are certainly diabetes. Diabetes is an independent risk factor for heart disease. What does that mean? That means, we have all these other risk factors and they have a weight to them. Diabetes, when you're doing the risk calculations, it's calculated the same as if you have heart disease. And of course, the better you keep your diabetes under control, the lower your risk is there. Any inflammatory conditions, so psoriasis, rheumatoid arthritis, lupus. Remember I said that the basic problem that starts in those arteries is inflammation in that endothelium. And then the plaque, the cholesterols and the cells and that start to adhere to those inflammatory cells. So if you have an chronic inflammatory problem, your risk goes up. They talk about metabolic syndrome. So metabolic syndrome is a condition that a lot of us have. And you look at the criteria for it. Any 3 of these are positive, you have metabolic syndrome. And that also increases your risk of heart disease and issues with your cholesterol. So what are part of the metabolic syndrome? They increase waist circumference. You think, what does that mean? So what is that? They're looking at where you carry your weight. So if you carry a lot of your weight within your belly, that does increase your risk. So the increased waist circumference. triglycerides greater than 150, high blood pressure, elevated blood sugar, your HDL or happy cholesterol less than 40, and chronic kidney disease. So any of those taken together can be this metabolic syndrome that you'd want lower LDL goals. So there's primary and secondary prevention also. And when we talk about primary prevention, in the context of heart disease, it means you wanting to prevent heart disease. So someone that hasn't had a heart attack, isn't being treated for angina or any of those things, but has risk factors. That's the people we want to do primary prevention on. So again, watching their lipids, weight control, all these things we'll talk about a little bit later. Secondary prevention is when you already have heart disease, you've had a heart attack. Now we want to prevent you from having anything else. I just wanted, this is kind of off topic, but there may be some controversy or some confusion, I should say, about the baby aspirin. For years, for primary and secondary prevention, it recommended a baby aspirin a day. Now, with more studies out on it, they no longer recommend daily aspirin for primary prevention, which means for someone who doesn't have heart disease but has risk factors. Secondary prevention, if you already had a heart attack, you already have coronary disease, you may be on aspirin, baby aspirin, that's up to the doctor. But for primary prevention, they found that the risk benefit really wasn't there. You do have a little bit of a risk of GI bleeding, gastric bleeding, things like that. So that's no longer a hard and fast rule for, again, primary prevention. So when we talk about the VLDL, that's the very low density lipid profiles. It does increase lipid proteins, excuse me. That does increase the risk of plaque formation. It's associated with triglycerides. So again, more with your carbohydrate intake. And your goal should be less than 30 if that's in your profile. And not all profiles will give you that. Triglycerides will definitely be in the profile. Those extra calories that we eat from my favorite foods, baked goods, cookies, bread, are converted to triglycerides and stored in fat cells. They can be released for energy as needed. So, you know, when we eat the proper amount, our body does this, again, as a redundant system that we have more energy and when we need it. Again, associated with carbohydrates, and the goal is below 150. So again, an overview, what they talk, when the doctor, you see on your end of visit sheet, and it has your diagnoses listed, and it has dyslipidemia. What does that mean? It refers to abnormal levels of circulating total cholesterol. So if your cholesterol levels are high, you'll be diagnosed with dyslipidemia. Sometimes they'll say hyperlipidemia, which means high lipids. But dyslipidemia means that you have dysfunction in your lipids in your blood. So that will be a high LDL generally and a low HDL, and high or plus or minus high triglycerides. And again, it's an important risk factor for coronary disease and stroke. So again, going back to these risk factors, there's two types of risk factors. There's risk factors we can't change. I can't change how old I am. We can't change our age. And there's modifiable risk factors, things we can change. So in non-modifiable, a risk is men over 45 and women over 55. Premenopausal women have some protection against the lipids and the heart disease problem because of the circulating estrogens. When the estrogen levels go down, our risk is about the same, though there are some studies that show us that when we have immediately postmenopausal, we do have a bump up in our lipids. Gender, men tend to have more issues than women. Heredity and genetics, can't get by that. You have a hereditary issue with cholesterols. I mean, there is some hereditary hyperlipidemia where even people in their 20s and 30s have very high LDLs genetically. But, we all know people who can eat whatever they want to eat and their lipid profiles look beautiful, and other people that struggle and do everything right and their profiles don't look good. And a lot of that has to do with our genetics and our hereditary components of our cells. Family history of coronary artery disease is also a non-modifiable risk factor, especially if the person in your family had coronary artery disease, heart attack before the age of 55. So what are the things we can modify? Big one, smoking. Smoking causes inflammation in the arteries. It also causes our platelets, the cells that help us clot, to be sticky. So now we have inflammation in the arteries and sticky platelets that start to stick to that inflammation, and the whole start of the plaque cycle. Also smoking, you saw the muscles in the arteries. Smoking will constrict the arteries. So now you got a smaller artery, inflamed, and sticky platelets. So that's a perfect setup for coronary artery disease or disease, blockages in the brain or anywhere, legs, anywhere. So smoking, big thing to get rid of. Type 2 diabetes, not necessarily can you modify it by getting rid of it, but you can keep it under good control. And the better control you keep of your diabetes, the better it is for all your organs, but particularly within the heart. Obesity, be it a healthy weight, your diet, which we'll talk a little more of. You can exercise. And, when you say exercise, everybody thinks, you need to, I don't know, do a Buffalo Bills workout. But, walking, I used to tell my patients all the time that had lung disease and it was very hard for them to breathe and do exercise. But, just to walk, or a stationary bike, just to get, some level of activity. Also, excessive alcohol use, that will damage the heart and increase your lipid levels. So that's something you can modify. So there's this risk calculator. I'm going to try to pull it up. Last time it didn't work very well, but we're going to try it. So, I think we have it. So this can be found, and I have it in the notes, so you can pull it up yourself. And this will calculate your risk. So I'm going to put some of my stuff in. If anybody wants to jump in with some of theirs, or just, like I said, you can pull this up at home and do it. This is the risk calculator that almost all of your primary care providers and cardiologists use. And many of them have them right into their electronic medical records now. So they pull it up so you can see it. So let's say I'm a female, 63, white. So my labs, sorry to say, my last cholesterol, 215. My HDL, happy cholesterol, 66. My last systolic blood pressure was a little high. I'm not diabetic. I'm not a smoker. I do have treatment for high blood pressure. So what's my recommendation? So I come out as intermediate risk for a 10-year cardiovascular event, stroke, heart attack, things like that. So 7.1% is my calculated risk in the 10 years. So that's intermediate. If I had optimal risk factors, it would be down to 3.2%. So what is that going to tell my doctor? Consider moderate intensity statin if my LDL is higher than 70. So this is how we figure it out. What you should be on, the recommendations for a statin. If you have less risk factors, it may, and they even talk about your lifestyle recommendations and the guidelines. So let's go back to, so there is the website for that. So again, a little bit more about the atherosclerosis and the cholesterol. You look at a normal artery, you got good blood flow, nice smooth edges. None of us live to any kind of reasonable age without some of this phase 2 stuff going on. It is normal wear and tear on the arteries. There, injury someplace, and then you get a little bit of these plaques. Phase 3, you really start to see the effects of this plaque in this artery, and you see that the blood flow is a little bit slower. And this may be somebody that does fine, but then maybe goes to exercise or does a little bit more exertion than usual, and maybe starts to be short of breath or have some chest pain because the flow, now that your heart needs more blood to exert itself, it's not there. And of course, here's a very narrowed artery, and at risk of completely closing off. When arteries supply blood flow, they supply oxygen, they take away carbon dioxide. So whatever organ is downstream from this, say the heart, that heart muscle that's downstream from this artery is not getting enough blood flow. But if this completely cuts off, it's getting no blood flow and heart muscle dies, and that's a heart attack. And this is a look from the inside, a picture, of course, from the inside of how that looks. And the edges here on these plaques are generally not smooth, so they're catching more cells as it goes through the artery.
Hey, Sue,
Yeah.
we gotta move, we gotta move back to the slideshow.
Oh, and I see a slideshow here.
Oh, you do? Okay.
Yeah.
I don't see it here. I still see the website there. But maybe if you click in this.
Okay. Sorry, guys. Okay, let's do, I thought I was being so good with going back and forth here. Okay, we'll stop sharing that. How's that? No.
Don't see it, but if you go back to share.
Okay. All right.
And then we might have to like click through up to
Yeah. Oh, I think.
But I liked the calculator.
Thanks. Yeah, last time I couldn't get it up at all. So,
Yeah, that's really good because
I have
you'll
it
know
down
the
perfect.
labs from the Quest docs you can find online now. So that's cool.
Yeah, that's nice. You can just pull them up on Quest and just put your labs in and figure out what your risk is.
Awesome. Okay. I
Okay,
see
so
it
we
there
talked
now.
about, you see it now? So here's
Yeah.
this is the artery that we're talking about was so clogged that you can see so narrow, it's not going to take much to block that off. And then the heart muscle downstream will not get any oxygen and will die if it's not corrected quickly. So those are the stages of artery narrowing. They don't work in a precise time frame, like this is going to happen 5 years or this. Sometimes there's a rapid increase if there's a lot of inflammation or changes in your weight and your diet. I don't think most people who are already not smoking don't start smoking at 60, but if you started smoking. So there can be it can be some rapid increase and then stable for quite a while. It's very individual how these plaques are formed. So the first line treatment for dyslipidemia or problems with your cholesterol is lifestyle modification, which, who wants to, give me a pill, bring my cholesterol down, because this is hard stuff. I realize that. I try to live it. It's hard stuff, and it gets to be harder for most of us during the holidays. But the first line is to decrease your LDL and with diet. And you can do, by diet, decrease your LDL by 10%. So that is significant if you're talking, you're trying to get from 120 down to 100. So what does the diet consist of? Low in saturated fats. So saturated fats are those, animal fats, less lean meat. We do need meat. People don't need it if they're vegetarian, but, it's okay to eat meat, but lean meat, chicken, things like that. Avoid polyunsaturated fats and trans fats. These are like all manufactured fats that our bodies don't know. They don't know what to do with those because they're not naturally occurring. So you need to take a look at your oils that you use. Again, you need some fat in your diet, but you want to maybe use oils, and we talk about healthy fats like olive oil. Look on the label if it's polyunsaturated. I think they've gotten rid of trans fats in our state. But again, taking a look at what kind of fat is in there is also important. So healthy fats are, again, olive oil, different, maybe the canola oil, fatty fish, salmon, things that have fish oil, and less carbohydrates because that will also increase your triglycerides. So low in your saturated fats, meaning you don't have to get rid of all the animal meats, but maybe smaller portions. We tend to have, and I know in my family too, the big portion of meat and everything else is smaller. Instead of having a smaller portion of meat, like a fist size is what they say, and having the more vegetables and things on your plate. And read labels, get rid of the polyunsaturated fats, and try, add the healthy fats to your diet. Weight loss, try to get to an optimal weight, and increase your exercise or activity. Again, I'm not talking about, going to the gym and lifting weights and all that thing, but what your kind of, activity, and look for activities that you enjoy. Mall walking or things, things like that, just to keep things moving. Smoking cessation, huge. Good blood pressure control or blood sugar control, really for all of it, but especially if you're diabetic, and keeping your blood pressure within normal range. And besides the medication, if you lose weight and have a little bit more activity, a lot of times your blood pressures will get improved. I see a question about monosaturated fats. The those are, to the best of my knowledge, your low saturated fats, your more naturally occurring fats, I believe. Polyunsaturated fats they're chemically changed fats. I think they did those more for shelf life, actually, than anything else. Okay. Sorry, I'm going ahead again. Okay, so these are the things that we can do. I can do. My risk isn't that great. Diet, weight loss, increase my activity, keep blood pressure under control. If you're diabetic, keep your blood sugars under good control. And don't, yes, avocado oil. Yeah, it went pretty quick. Avocado oil. So any of these naturally occurring oils. So things in avocados or coconut oil is very popular now, though it's pretty high in fats. So you got to watch that. It's not it's not polyunsaturated fats, but just the fat content is high. Same with different nuts. Nuts are good too. They have good healthy oils. You just, again, have to watch. You still have to watch your calorie intake with them. So let's say you did all your lifestyle modifications. Let's say, like for me, I'm an intermediate risk, and my doctor says, we really should treat this. And common thing now is, especially if you have intermediate or a higher risk, to treat with a statin and also do lifestyle modifications. It's not one or the other. Lower risk, you could try lifestyle modifications for a while and then start to maybe think about drugs. But if your risk is high for a cardiovascular event, these lifestyle modifications like your diet and weight loss and things, this isn't something you're turning around in 6 weeks when you go back to the doctor. I know this. This is a year or two project. So we need to protect me while I'm working on my lifestyle modifications. So again, the medications are added to the lifestyle modification. The statins are usually the first line treatment. They decrease the cholesterol by 25 to 60%, depending on your own body, how it works, how it responds to it, and which drug they use. If it's used in primary prevention, so again, I'll use myself, someone like me, I've never had heart disease, I haven't had a heart attack, it will decrease my risk of heart attack, death, and cardiovascular disease by 30%. And that's huge. So if you're like me, I don't want to be on any more medication. But when you look at these numbers in these studies, decreasing my risk of a heart attack in the next 10 years by 30% is huge. Nothing's going to give you that bump like the statins do. Again, still with lifestyle modification. Secondary prevention, so for you folks who have already had a heart attack or have been diagnosed with coronary disease, it decreases coronary heart disease death by 40%. Again, that's huge. And all-cause mortality by 30%. So decreasing your death, coronary artery disease death by 40%. Again, there's not a lot of things we can do that can decrease death rates like the statins can for coronary disease. And I like the, that's me. I like the cartoon. I just want to load up on a bunch of statins I've read about and eat as many fats that I can. I think we all feel that way. Just give me some more statins and I want to have a lot of cookies for Christmas. So again, how do the statins work? And these statins are like the atorvastatin, anything with statin on the end. Atorvastatin, rovastatin, their trade names, Lipitor. Atorvastatin is nice because it's now generic. So it's cheap. Crestor, but anything that has statin on the end of it is a statin. So it decreases your LDL cholesterol by slowing down liver production of cholesterol and increasing the liver's ability to remove the cholesterol. So it slows down the production, and then it makes it easier for the liver to remove the cholesterol. And there are some common ones. There's other ones here, but these are probably the 4 most common ones that you'll see ordered. The atorvastatin, that's generic, that used to be called Lipitor. Lovastatin, simvastatin, rovastatin. Generally, these are very well tolerated drugs. A lot of people, and if you go on the internet, there's a lot of issue, non-scientific talk about the statins and people having problems with the statins. Anybody can have any problem with any drug that you take, and no drug is not without its side effects. Again, the statins are generally very well tolerated. There's like a gazillion people in the United States on statins, so we have a very large population to look at to see about risk factors or side effects, excuse me. The 2 most common things, the 2 things that I've seen, actually one more than other, is muscle aches. And it tends to be muscle aches in the big muscles like the thigh muscles or the shoulder muscles, the big muscle groups. There's sometimes it's just transitory when you first start it. Sometimes we can bring the dose down, they go away. and there's other medications. Even within the statin range, some of the statins are better than others with muscle pain. We need to monitor liver function. Very rare. I can't, I was trying to remember how many people I needed to decrease or take off statins because their liver function blood work went off, and it was very, very, very rare. I couldn't remember. I think the sometimes you see it with really high doses, which are probably being followed by cardiology. When you get up into the high doses, you have to watch the liver function. So, and also if you have other risk factors, like if you're a heavy drinker, that puts a lot of stress on your liver, and then we put a statin on. But those are generally the two things that you watch, you watch for. There's other medications not used very often, but you may hear of them, bile acid medications that kind of sequester you. Some of the cholesterol in the bile helps bring the cholesterol, like the fiber brings the cholesterol out. So more of the cholesterol is sequestered into the bile acid that you could then eliminate. I think these, because of the way they work, have an issue with diarrhea. I don't see these ordered very often. Again, this would be someone who for some reason is intolerant to the statins and needs it. Niacin, another good drug. It's actually a good drug for bringing triglycerides down. That has some uncomfortable side effects too, mostly headache and flushing. And you have to take some, people take aspirin before so they don't have the headache and the flushing with the niacin. So I didn't use that one as much. If they had a normal cholesterols and just their triglycerides were up, and they were up significantly, we tried some niacin. Fibrates, kind of the same thing, the fiber and bringing the cholesterol into the fibers, into the fiber in your gut, and getting rid of more cholesterol. Again, don't see these that often. Sometimes people need to be on a couple different types of cholesterol lowering drugs. So they'd be on a statin and maybe one of these. But generally for first line treatment, I didn't see it. So that's Bryce Canyon. Where is it? In Utah, beautiful place, because it's relaxing to look at and to walk around, and stress management is an important part of heart disease problems too, and cholesterol. So I will open it up to any questions. I will get rid of the PowerPoint.
All right, if anyone wants to ask some questions over in the chat box, or I can go into the unmute where you would raise your hand and I can see it. So let me head over there.
Sorry for some of the issues with, so I'm looking at the chats. We talked a little bit about the healthy oils, avocado oil, the vegetable oil, you have to take a look at the label and see how they made this vegetable oil. So I would look at the label on the vegetable. So high LDL, if no risk factors, and low HDL, and triglyceride is not a problem. No, it can be a problem. It doesn't necessarily mean we have to treat it with medication. Because it may become a problem down the road, or your risk factors may change. you get more points on that risk factor calculator the older you get. So the older you get, if I'm putting my numbers in and I put in I'm 30 years old, I'm not going to be an intermediate risk. But if I put in that I'm 70 years old, I'm going to be a higher risk. So you still want to get that LDL down and hopefully get the HDL up. How do you do that with those lifestyle modifications? You know, if you have no risk factors and your doctor does the risk calculator and it comes in low, 3%, he's not going, or she is not going to put you on a statin because your LDL is 140, but you still need to get that down, maybe down to 120. Diet, activity, weight loss, all those things we just don't want to do, or I don't want to do. Activity and exercise brings up your HDL. So those things in combination can make your profile look better, because eventually down the line you may be adding more risk factors. So I hope that makes sense. Yeah, we'll get the website. Is butter Well, I'm going to tell you my own personal preference. I've tried to, one of the things I've tried to do with my diet, and trying to get more of an anti-inflammatory diet, is to look at things as what is real food, and what is, more manufactured food. So I prefer butter because butter is real food. It depends about, again, which vegetable oil you're using, and how much, and if it's, a good vegetable oil or not. But I tend to go with butter over vegetable oil or margarine, or what my grandmother used to call oleo. She used Crisco. She used a lot of Crisco. So I usually go with the butter. I don't know if there's any studies showing which is healthier, but if I have a choice, I go with something that tends to be a naturally occurring food. What can cause a sudden rise in triglycerides? Basically, the most common thing, a sudden rise in triglycerides, is a sudden rise in your carbohydrate intake. There is some talk that there's maybe a stress component also, but basically it's a increase in your carbs. The other thing I want to mention too, and I didn't in the talk, that goes along with this with the lipids, is there's some medications that will also increase your cholesterol, in particular your LDL and your triglycerides. So if you've started a new medication, that may be a part of the issue. The thing that comes off the top of my head is steroids. Steroids will increase that, your lipid profile. Some medications they use for rheumatoid arthritis will, some chemotherapy. So if you've started a new medication, that that you may want to look that up and see if that's that part of it. But if nothing else has changed, and your triglycerides went up, like for me, it would be I would have eaten too many Christmas cookies. Can foods help to get rid of plaque and help? This is a huge question, and there's studies and there's a lot of things on the social media about if you drink this or you have sour cherry or whatever. There's really no good evidence or the studies that once the plaques are there, you can have them regress. There was a big, who was that guy? Dean. Do you remember? My mother's here listening to. He was a cardiologist, very big on plaque regression, did these huge studies and these diets he had out. One cardiologist said to me, yeah, it's like eating sticks and grass. But it was very intense. These people lived at this place, and Yeah, a very strict diet, stress management, exercise. They did a test, called cardiac catheterization to look at the plaque inside the arteries. And then they did it at, I don't know, say 6 months in a year. And some people did have regression. They were not able to replicate, which means no one else was able to do that study again and have the same results. Because when we really do science studies, they should be replicated. You don't just do one study. So the long-winded answer to this is probably not. I think the goal is to prevent further plaque formation. In the initial, when it's kind of soft and gooey, there may be some way to lose some of that cholesterol, but I have not seen any real scientific studies that show that any particular food or diet will cause them to go away. Will certainly cause Ornish, that's it. Dean Ornish, thank you. Yeah, I heard him speak actually at the time too. But certainly when we talk primary prevention, if we can keep those plaques, I mean, all of us, unless we're very young, but all of us, when we pass away, if we did an autopsy, would have some plaque in our coronaries, be just from, again, normal wear and tear. But if it's 20, 30%, because they measure them in percents, that's not going to cause any illness. So whatever you can do to keep that healthy lifestyle. Yeah, no idea carbs are related to triglycerides. Yeah, because they come on the lipid profile. So, okay. All right. Anything else? Any other questions? If you do, just email them to Kitty. Sorry for a little bit of the stuff with I'm trying to be
I
so
thought it went well.
so
That's fine.
techy. And I wish you all good holidays, and we'll see you next year.